taken all the time, but it's very important that I tell you about the Palliative Care Association of Uganda, and I'll, of course, use the minutes very well. Now, I gave a slide just to show who we are. We are organizing these events together with the Ministry of Health, and we are coordinating civil society in this country to advocate for palliative care. And that's who we are. We are the National Association for Palliative Care Providers. I made sure that I put this slide in case you are in the room, you make sure you become our member before you leave. Because we want all of you to become our members. We have a vision that palliative care should be accessible or accessed by everybody who is in need. Right now, I am going to show you a very brief map at the end, but there are 226 facilities that we know that offer a form of palliative care, but there could be many more. And every year we get a change. Whenever somebody is transferred, we have some slight change. We would like to make sure that we have all of you as our members. I mentioned that. And we also have a special category of life members, and we have some life members in the room. The next slide talks about our focus areas. We have finalized our strategic plan for the next 5 years, and these are our focus areas, and I'll mention very quickly. We would like to make sure that we do capacity building, the training, the mentorship, the support for people who are providing this care is there. Now, we have some scholarships. We give scholarships to people who are doing a diploma in palliative care, a bachelor's in palliative care, and now we have extended to people who are doing a master's, in palliative care. When it is next year, we request that we receive more applications. We are doing advocacy. Dr. Mwanga hasn't shared, but we are on his case. We want a national palliative care policy. We want the national palliative care standards. We want the national palliative care communication strategy. We have been on our case, and that's why you'll see behind there we have even some people from other civil society organizations who are our partners. I saw somebody from ISA. I also saw somebody from Uganet, and these are lawyers. They come to be part of us to advocate. We talk about research and information. This is the hub. This is the center. We would like to interest you to do research in palliative care. We have put a small amount of money for people who will be doing research in palliative care at master's and at PhD. Beginning next year, you can approach us. We have a research agenda that is thorough and will interest you. The rest of the things, governance and sustainability, is what we emphasize with ourselves, but also with our members. Resources are a very important deal in our country. We would like to make sure that once you're in palliative care, you provide the service with integrity, with professionalism. Lastly, just to emphasize that all of us need to work hand in hand to make sure that this service is spread across the country. This is how it looks like. You will see that we still have some districts shaded white completely. Those districts have no palliative care facility offering. They have no health facility offering palliative care at all, where you see white. And right now there are 40 districts. Okay, the districts keep increasing, as you know, in our country, but there are 40 in total. Where you see a little bit of light, we have only one facility. That means in case of a transfer of a health staff, sometimes the service is not there. Where you see a little bit of shaded in dark, that's where we have the concentration, and those facilities are less. They are actually only 72, and they are mainly in cities, the cities that were named recently, and in Kampala. I want to thank you so much, and to thank the team, and to thank Lisa for organizing all this, and to make sure that all of us come, plus the rest of the team from Bikau. If you can please stand and wave like this. They have worked so much through the Palliative Care Week, so thank them. They are ladies who are here, but we also have some gentlemen as well. I thank you and wish you a great lecture. Thank you.
Thank you very much, Mark. I too would like to recognize the presence of Merriman, doctor, who taught us. And today being World Teachers Day, there's many teachers here that taught me, by the way. Today being World Teachers Day, we'd really like to recognize all the teachers in the room, our lecturers, our senior colleagues. And in primary school, I've noticed that they've got a way of celebrating each other. So when you have a birthday cake cut, they say, let's pour some flowers, you know. So let's give our teachers some flowers. Oh, thank you. Our permanent secretary in the Ministry of Health is yet to arrive. And when she does, she will provide her comments, welcome us, thank us, and maybe stay longer to hear from us. So without further ado, we will start the public lecture. So I would like to introduce the first one, who is Dr. Fred Nakwagala. He is the he's the clinical head, Directorate of Internal Medicine in Mulago Hospital. He is a bioethicist. I say that slowly because it's quite heavy. He's also a senior consultant physician in endocrinology. He's a chair of the Mulago Research and Ethics Committee. He's my teacher, and I'm very grateful to introduce him to give the first talk on medical conditions that require palliative care other than cancer. You're welcome, Dr. Fred.
Good afternoon. Good afternoon, ladies and gentlemen. I think it was some time back, either I was in medical school or I was a young doctor when I met, I first came into the word palliative care by Dr. Way. And the word then looked very strange because I'd never seen it in any textbook of medicine, so it was quite something interesting to learn at that time. My simple talk this afternoon will look at the palliative care needs in internal medicine in Mulago Hospital. And it will basically just give you a snapshot of really how much gaps we have in this business of palliative care. Next slide. Now, these are the different units we have in the Directorate of Internal Medicine. And you could see there a small bullet called the Palliative Care Unit, which is one of our babies. And so we're excited that we are able to have a palliative care unit within our directorate. So within these units, mainly the biggest work is, of course, for the units that are handling the critically ill patients, like medical emergency and the TB wards and the wards that should be 4B and 4A. We have a ward that began yesterday, and that is Ward 11, so the palliative care team may not yet be aware of that. So your work is going to expand. Ward 11 is a general medical ward that we are creating in Old Mulago that will be having all types of patients, and I'm sure that palliative care will be involved there. The pharmacy department is within our directorate, and it's very keen in palliative care services, medical social work, and the community health department. Next slide. In my personal estimate, about 14% of patients in medical wards are end-of-life patients. Of course, this statistic will vary from day to day, meaning that every 7 patients you are seeing, 1 would need the services from palliative care services. Of course, the unit will be giving you the actual figures of the number of patients that they serve, and you'll see that they are able to serve really quite a small fraction of what we have. Our mortalities range between 20 to 30%, particularly on the infectious disease ward, may go up to 34%, largely because of opportunistic infections with advanced HIV. The common conditions that we receive with end-of-life care issues include what you see on the slide, but not everything is here. The chronic liver diseases, as we know, our gastrointestinal ward is fully packed with particularly hepatocellular carcinoma and other forms of liver disease like liver cirrhosis. We have a lot of inoperable heart conditions, especially those to do with hypertension and its complications. Chronic lung diseases are a very big problem. Now that we are grappling with environmental pollution, diabetes is everywhere, and because our patients come in late, they're quite diseased with complications, mental health issues, dementia and others. Fetal medical care is still acceptable and demanded in our settings, and this is one of the big social cultural contexts that we have to look into. It looks like dying in hospital is preferred by people and by the attendants here more than dying at home. Of course, there are variations here and there. The issue of sickle cell disease and this pain is known to everybody. The issue of dialysis, and particularly the lack of, the inability to pay in the absence of organ transplantation is a very big issue here. Older persons with various health issues. The proportion of older persons above 60 years is increasing in the country, which is a blessing, but at the bedside, it means feeding more patients to us with currently now, the biggest cause of mortality, in addition to HIV, is stroke. And I hope members are seeing where the trends are going now. The Dr. Mwangas are preventing malaria and other things, and now people are living long enough to die of stroke. So right now the stroke wards are full and people are really doing badly. HIV and then arthritis. We shall discuss a bit about the goals of palliative care related to internal medicine, and of course these mirror the same goals that we have in palliative care, improving the quality of life of patients and helping families and loved ones to cope and connect, pain management, treating symptoms, including prevention or diminishing those symptoms and helping people to cope with those symptoms, counseling and therapy, assisting people with living, helping patients become more mobile than they are. Then the issue of connecting family, friends, loved ones, and the wider society with the client before us. The issue of understanding. Coming in from a bioethics perspective, I take that as very key, because I know that the bigger majority of our patients do not understand what's happening to them when they're in a hospital. They're like people boarding a ship where they don't know where it's going. Help for families and loved ones, and then the spiritual support. I'm going to dwell more on what are the glaring gaps that we are seeing within our services in Mulago Hospital. Quality of life is rarely looked at as an endpoint in health service provision. I've not seen a framework for assessing outcomes in the Ministry of Health in terms of quality of life. Dr. Mwanga, I'm yet to see that statistic come up. I don't know whether you people have it somewhere in the health sector annual reports, but I've missed seeing it. And in our training as medical professionals, this is hardly mentioned. All we know is patient has a fever, shoot down the temperature. Patient has convulsions, control the convulsions. Patient has sugar, go in the endocrinology unit, bring down the sugar, normalize it and all that. But quality of life is rarely looked at, it's rarely taught, and those concepts are not given to us. We have a wrong conception of what health means. We only have a physical concept and lack the psychosocial and the spiritual elements of that. We may be having it within our day-to-day life, but I don't see it happening within the way we are doing our work. We have huge opportunities for research and setting definitions and standards for quality of life from anthropological basis to integrate with the biomedical basis. So we are more looking at health as physical. And I'm sure almost all the budget of Ministry of Health goes on solving the physical issues of health. I've been to some hospitals like in the US where the reverend, the priest, is actually a paid person of the institution. I'm yet to see that here in Uganda, where an imam is paid by Mulago Hospital or by public service, that the imam is going for the interview as the imam of Mulago Hospital. Then patients and families have conflicting values and understanding of end-of-life issues. I'm sure the palliative care team always has this tussle. You're offering services to a patient. The patient is saying something different from what the family and other people are saying. And those conflicts occur at the bedside, and we have to bear them. We need to have more evidence on how connections can be made rather than simply using textbook models. I'm yet to know whether the Ugandan palliative care professionals have done appropriate researches to inform us on this, or they are transposing issues of Seattle into the Ugandan context. Concepts like writing wills, making advanced directives for healthcare are foreign and are not practiced. And it's also possible that we don't have any policies to guide the healthcare workers on this. Dr. Liz, you remind me whether we now have any of these policies for advanced directives and whether the Ministry of Health has put them up. But these are very vital for informing us on how healthcare professionals can guide people on how to express what they wish to be done. This should come in handy now that we are about to pass the organ donor and transplant bill into an act of law, and we need to know what are the wishes of people. Should we harvest their organs if they are brain dead and that kind of thing? All these gaps are still present. We need a mindset change on the part of the healthcare workers about leaving clients in pain and distress. I personally find when I walk into the ward, and I find people are very comfortable having patients crying out in pain, patients really distressed. You can enter a ward and you just see distress and pain. And then the healthcare professionals are very happy, not happy, but they're not concerned about it. And I keep telling them, I wish you could enter a hospital in the UK. They can't accept what you are seeing before you. So we need a mindset change on this. Sometimes even the drugs used are there in the drawers, the pethidine is there, but the people are slow, I don't know why. Healthcare units lack diagnostic and care facilitation, including human resources, drugs, sundries, and devices for alleviation of pain and other end-of-life symptoms. I'm sure the Ministry of Health is aware about that. There's still lack of commitment to creating critical mass of trained professionals and dedicated service providers to this segment, who are told of the training programs that are coming up within the Palliative Care Association, and I think that is key. The concept of caring for psychosocial aspect is largely lacking in training and major design of healthcare service delivery. For example, When we had the COVID-19 pandemic, we closed all our mental health units and we turned them into COVID treatment units. And guess what? Right in the middle of the COVID pandemic, mental health issues were among the forefront issues that were difficult to deal with. Concepts like assisting people with living are hardly taught to medical students, trainee nurses, yet they impact heavily on patient outcomes. With little budgetary support for needed devices or even planning of infrastructure. Looks like even nurses in training look at assisting the patient as outside their scope, and we have left it to attendants. This is something we have bred over the last 20 or so years. When I was a young medical student, what the nurses were doing and what nursing students were doing is different from what they do now. I remember those days, it was the role of a nurse to sit up the patient in bed when the consultant is going to examine. Nowadays, it's totally different. And it's especially worrying when you sit on the trainee nurse who stands a kilometer away from the bed of the patient. Patient mobility is not structured as a clinical intervention, and I think we need to change this. We all know that poor mobility of patients leads to depression, bed sores, contractures, disuse atrophy, hypercalcemia, and the fatal DVT. Actually, the rate of death from deep vein thrombosis in this country is unacceptably high. It has reached epidemic proportions. To understand that, you just need to walk into one of our postmortem rooms. And part of it is because we don't pay attention to just simple things like mobility and emphasizing that. The concept of connecting patients with loved ones, families, and friends is usually neglected or not embraced at all. We don't think of it as something key. And because we're a paternalistic society, we did take choices to patients, and clients lack autonomy. I'm sure the palliative care professionals will testify that many times when you approach with the typical palliative care approach, patients become surprised. Oh, you mean a doctor is asking me to express a choice? Because they know what doctors do. Just walk in, give me your balm, and have this. So the concept of supporting families, loved ones, and friends is foreign to healthcare workers who limit their contract to serving the patient. For us, we've been taught, serve the client before you. We didn't know that there's also the burden of looking after the family. It's only the palliative care team which does that. For those who treat pneumonia and pneumonia alone, we don't ask for the people who are left at home. So it's a gap that we need to have. Healthcare professionals are not trained on how to guide patients around religious issues. Yet traditional religious ministers are very few, or they haven't been integrated within the healthcare services. So within Mulago, this is what we have done. We are putting up a lot of efforts at obtaining human resources. And the top management has readjusted the human resource structure, which it has submitted to the Ministry of Health for its approvals before it goes to the public service. And we have established a palliative care unit to be manned by a senior consultant, 2 consultants, 2 medical officers, special grades, and I think about 8 palliative care nurses. So we have agreed on that, and we are now waiting to hear from the Ministry of Health. Of course, we're working with the Nakere College of Health Sciences Palliative Care Unit, which is operational now, and we provided space on Ward 4B for their geography and their address. I think I've come to the end. Thank you very much.
Thank you so much. CIUHI had team, and that team makes decisions on advanced patient management. So I would like to welcome you, Dr. Peter. He will be speaking on the palliative care for people with cardiovascular disease. Please allow him 3 minutes over the 10 because we don't want to miss out on any of the information they have to share.
Thank you very much, and good afternoon to everybody. It's indeed an honor to be here today to discuss a topic that I think as health workers we tend to avoid. Nobody usually likes taking responsibility to give bad news, and probably we are also wired in such a way that we are always giving hope, even when it's likely that that hope has a very short lifespan. So patients begin to suspect that doctors tell lies, that you're going to get better, you're going to get better. And we need to actually draw a line between giving true hope and false hope, because that impacts a lot on the quality of the patient's treatment and also impacts a lot on the family. The families usually appreciate the truth as long as you present it in a way that is acceptable and digestible. So today's topic is really just to have a bit of discussion on palliative care in cardiovascular disease. Let me see. Okay, this is just to start. I was asking myself what are the definitions, and there are quite a number of them. There's really no best definition, but these are some of them, and basically they are all looking at issues to do with family and patient and optimal health. I think quality of life is very important, and Dr. Nakwagala has already alluded to it. And really we are looking at preventing and treating suffering, because that is really what is most important. It's also an interdisciplinary approach, so it involves not only healthcare workers, but the family, psychosocial support, and spiritual interventions. And these usually should be well coordinated in order to make sure that the patients and the attendants get the best possible outcomes in managing their loved ones. In the WHO approach, it's basically an approach that improves the quality of life and their families facing problems associated with life-threatening illnesses. And again, it is addressing a problem that is unlikely to go away. How do we accept this challenge? How do we adapt to this challenge? And how do we make peace and reconcile with all those challenges that are coming? And it is definitely more than just pain treatment, but also looks at psychological and spiritual support. And unfortunately, the last two are usually not present in the hospitals. And unfortunately, like Dr. Nakwagala mentioned, a lot of patients are brought to hospital to die. And yet you're forgetting that the most important other areas apart from pain are the psychological and the spiritual components, which unfortunately are not commonly found in hospital, one. And two, this patient is usually surrounded by so much misery and suffering from other patients that he does not have time to internalize his own problem, and you actually distress him more by watching other people depart in pain, and he knows that anytime he or she knows that this is what's going to happen to me. So we need to be objective in how we handle our patients. We need to look at the environment. Hospitals are not death destinations, and I think we need to think through that carefully. So Cardiovascular diseases are a leading cause of death world over, and we are seeing an exponential rise in deaths due to heart problems. Every year it's envisaged that about 18.6 million people over the world die of heart-related ailments. And this is a number that is expected to grow. Even in Uganda itself, 1 in every 4 adults we know has high blood pressure, which is a precursor to heart failure and complications. So if I start counting here, I don't know how many of us would fall in that category. But we need to be conversant that, how do we manage this condition and how do we manage its complications? So some of the common complications we have here, I'm just mentioning for passing, coronary artery disease, which is on a huge increase. We now have a 10-fold increase in people suffering from heart attacks. Dr. Nakwagal has mentioned stroke. We have a Dr. Batambuze, senior cardiologist who teaches, and he always tells us one thing, that he would rather die of a heart attack than a stroke. And it was true, because he says when you get a heart attack, you exit immediately. When you get a stroke, you die slowly and painfully, and you agonize for maybe weeks, months, or years. And that agony is because there's no palliation for these patients. Peripheral arterial disease is a very debilitating disease. Again, main problem is insufficient blood supply to your limbs, and the main problem with that is pain. Towards the end, you get gangrene and all the other bad complications. We've mentioned rheumatic heart disease, a disease which is commonest acquired heart disease among children and young adults. Starts in at the early childhood, age of 5. And imagine getting this disease, if not well managed, and living with it to adulthood, you suffer a very miserable life. We've mentioned congenital heart disease. From the word go, you are introduced to this planet with a heart problem. And maybe from the word day one, you're getting operations, you're in hospital, you grow up never having an opportunity to live a normal life. And you must cater for the needs of these children and the needs of the parents, who are very devastated when they find out that their children have defects and may never be normal. DVT has been mentioned, again on the increase. And basically with most of these diseases, the final common pathway all these diseases lead to is heart failure. And heart failure is really a constellation of signs and symptoms that really make the life of a patient very miserable. So just synopsis just tells us here, we're just saying that palliative care is appropriate for any patient who has advanced illness, including patients with cardiovascular disease. And these patients not only suffer from dyspnea, fatigue because of the disease, but they also have a high burden of somatic symptoms, pain, nausea, anxiety, depression, and these other symptoms also lead to a lot of psychosocial distress, not only for the patients, but even the attendants who feel helpless. They want to help, but they don't know what to do, or they can't do anything really for these patients. So, world over, it has now been recommended that palliative care be incorporated into routine cardiovascular care of patients with cardiovascular disease. And this has become very apparent. Much as cardiovascular care has improved, we all have a lot of modern practices, modern interventions, heart assist devices, and all kinds of fancy things. They do help medically, but they do not remove the psychosocial burden. And definitely that has to go hand in hand with the care. This was again a slide that jumped the queue. Should have come earlier. But I think we have already mentioned this evidence, prevalence and evidence. So, where is palliative care applicable in cardiovascular disease? Elderly people. And usually, as we get older, it's either a cancer or a heart problem that's going to get us. Adverse heart failure, as we've mentioned, much as we have a lot of new medications, new interventions, pacemakers, assist devices, we have a lot of technology, but it doesn't substitute for the social aspects. It doesn't take away the fear of impending death. It doesn't take away the depression or handling of you living with a burden that doesn't really go away. And obviously, end-stage cardiac disease, because most times as the disease progresses, patients become aware that things are not getting better. Unfortunately, as doctors, we do not want to talk about that. We always say we have another alternative. And I'll tell you, I shared with one patient who actually knew more than I thought she knew. She went ahead and gave away her things, her possessions to her siblings. She prepared everything, and I confess I didn't talk to her about those details. I only found out after she had demised that she actually knew much more than I did. I think it was a very big lesson to me, but don't assume that your patients don't know. They do, but they need support, they need reassurance, they need time, and that time is important so that they can plan for any eventualities. Why should palliative care be included in cardiovascular disease management? As I mentioned, the conditions are usually complex. Much as you have a heart problem, the effects of a heart disease will impact anywhere, on your brain, in your kidneys, in your limbs, your appetite, poor absorption. So it's a very complex syndrome of a disease that it needs many people to help optimally manage these patients. We've mentioned symptoms, so we should alleviate symptoms and manage pain. We must reduce suffering for these patients. It's important as a holistic approach, and it also helps patients and families face the long-term challenges and burden of advanced disease. We should also help in coordinating symptom-targeted care for these patients, respectful of their wishes, their values, and their preferences. Fred has already mentioned the dogma of doctors issuing orders, but I think this should be a discussion. Patients should be able to tell you what they prefer, what options they seek, and how aggressively we should manage their condition. It's very important to relieve or ameliorate all kinds of suffering, and we know that poor health-related quality of life will always result in a deteriorating health, symptom distress, and definitely poor care in these patients because we omit important parts. What are the elements of this care? There are many, but sometimes we do not try to cure. So sometimes what we look at is what we call disease-modifying treatment. In other words, you just sort of help the patient overcome the barriers they are facing at that point in time. And this really helps to delay the progression of disease. It helps lift the patient's moods by targeting the underlying cause. Symptom control is also very important, and that should be addressed. They usually have the somatic symptoms, they have pain, and they're obviously anxious, the anxiety of their problems. We know they also have depression and spiritual distress. We should also provide support in decision-making with them. These decisions should also be shared, not only doctor-driven. And we doctors should also be sensitive and open to communication. Patients may give a suggestion, and they shouldn't be shouted down because it's their life in the end, and we need to respect their wishes. We must also take into account the individual benefits and risks associated with that care, and basically all the issues that are part of the complex conditions should be taken note of. So I'd like to wind up by saying our dictum as doctors is to lighten the loads of others, but best by helping the Lord strengthen them. And that alludes to the spiritual support these patients need. I would like to conclude and end there, and thank you for listening. Just a quick one. I'd just like to thank my team. We have a very strong team of palliative care staff here, the nurses from Uganda Heart Institute. And they've been very instrumental in developing our presentation. Thank you.
Thank you. I would like to acknowledge all the participants online, on YouTube, and on Zoom that are attending this very important public lecture. We will be taking questions at the end. I encourage everybody to jot those questions down so that the panel can then respond to them at the end of all the lectures. Our next talk is on the topic of palliative care at a national referral hospital in a clinical education and research setting. It will be presented by Dr. Elizabeth Namkwaya, who is a works with Makere Mulago Palliative Care Unit and the Palliative Care Education and Research Consortium. Dr. Elizabeth is a palliative care physician and an honorary lecturer in the Department of Medicine, Makere University. Her current role involves teaching medical students and postgraduate students research in palliative care and patient care in Mulago Hospital. A very warm welcome to you.
Thank you very much, Noella, for that introduction. And I thank PICAO for giving us this opportunity to talk about our work. Yes, so I'm going to talk about palliative care, mainly in the National Referral Hospital of Mulago. But also because Mulago initially was one unit and has split up, some information will be from other units. So the palliative care unit in Mulago National Referral Hospital was started in 2006 by the hospital management working together with the Hospice Africa Uganda. Prior to that, Hospice Africa Uganda used to come to Mulago to offer services. And also, Hospice Africa Uganda was working together with the Palliative Care Association of Uganda. And initially in 2006, they appointed 4 nurses to provide this care. However, they recognized that palliative care wasn't getting integrated, and they realized there was a need to have a multidisciplinary team. There was a lot of myths about palliative care, misunderstanding of what palliative care was, the myths about opioid use. So they thought it was very important to have education about palliative care and also to improve the credibility for palliative care. So in 2008, 2 doctors were added to the team, and an academic and palliative care unit was started with the objectives of providing clinical service for patients in Mulago National Referral Hospital. At that time, the hospital also included the Uganda Cancer Institute and also to provide education and training for healthcare workers plus medical students, and also to do research to inform care so that we generate an evidence base on which we could practice. The other objectives were for increasing the credibility for palliative care through advocacy and to have a sustainable service in Mulago National Referral Hospital. I'm going to concentrate on the first 3 objectives, which I was asked to talk about. So when we were starting the clinical service, we did research, which was published in these 2 papers. One was our research, which we did on the surgical and medical wards in Mulago National Referral Hospital to understand the palliative care needs that were there and how prevalent or what the need for palliative care was. And this research was also replicated by Dr. Mandwa later in the whole hospital through a census. And through this research, we found that the need for palliative care on the wards, for the 2 surgical wards and the medical wards, was 46%. And when the census was done, which included also obs-gynae, where there are few patients, the number went down to 37%. And it was noted that there was a very high symptom burden, high social, psychological, and spiritual needs, which were unmet. So we've given this and the small team, we decided that the best mode of care would be a consult service, where we would go to different wards and where we get referrals and see patients from there, and not have a ward of our own. First of all, there was not space, but also it would be impossible to have a ward with such a number. And we felt that if we started a consult service and jointly cared for patients, we would be able to skill other people who would see us. They see us, how we communicate, how we offer drugs. And actually, this was really true, because in the beginning, when we prescribed morphine, we would find the next day it would be stopped. And then we would ask the ward people, why have you stopped the morphine? The doctor would tell you sometimes that it's going to cause addiction, it's going to cause respiratory depression. And then we would explain the physiology, we would explain, say, let's try it. They hesitantly accept. And then the next day, patient hasn't died, patient is better. So they started accepting it. We have a strong support from the Department of Medicine and Mulago National Referral Hospital. And as Dr. Nakwagala said, we were offered an office on Ward 4B. We are really appreciative to the hospital administration and our clinical head, who has really fought so hard to make sure we get offices and other things. So we receive referrals from Mulago National Referral Hospital, from the Department of Medicine, Pediatric Surgery, and now there's a new pediatric oncology ward. But we still also get from Uganda Cancer Institute. When the hospital split, there was no new service in the Uganda Cancer Institute, so we still get patients there. And when the hospital was undergoing renovation, we went to Kirudu. We started working there, and when we had to return, we also couldn't leave them, so we also worked there. So to make sure that we meet everyone's needs, and yet we're a small team, we categorize our patients based on the severity or the complexity of their needs. So level 1 being the very needs which are simple, and 4 being complex needs. And level 1, the people we train, like medical students who become interns and nurses, can meet those needs, but we support them on the ward. So if they make a referral and we come and discuss with them and we say the need is not complex, we leave them to take care of those patients. Those level 1. Level 2 are the ones who've had more training, like the postgraduate students who are more knowledgeable, but also the link nurses. And level 3 is those who can just be seen by one member of our team. The needs are complex, but one member of the team can manage. And level 4 are those who need the whole multidisciplinary team. And we have come up with symptom control guidelines, which help especially level 1 and 2 to manage symptoms on the wards. And we have 11 protocols with different symptoms. And also when we did the needs assessment, we recognized a high need for social support, psychological support, and spiritual support. So we came up with a volunteer program. These volunteers, most of them are not medical. Many are social workers. They come and help us to provide that psychosocial spiritual support. Because we recognize that when you come to the ward, you're in a court, you talk to the patient, they are reluctant to talk about the other non-physical problems, because I think of the culture, they are used that you talk to the doctor, the physical problems. However, when somebody comes, is a social worker, maybe also they are better at communication, I don't know, but they tend to get information out of them, about those other needs. So these help us a lot in the social needs. They help us to liaise with other maybe pastoral workers. For example, if some patients may need a priest, if they will go to the church or an imam and get them. And also patients sometimes who don't have where to go at discharge, they will liaise with available hostels so that they can be accommodated there as they come back for review. And also they liaise with the hospital social worker when there is need for transport and all other social needs. So these are just some comments from our patients. appreciating some of the work, especially giving them time and listening to them. Over the last 10 years, we have seen about 12,500 patients, and the specialist team has seen 5,000, and we have the generalist team, the level 1 and 2 are more. Some of those come from the link nurses we've trained, and also the interns, and we just give them support. This is also shows the number of patients over the years, and initially, as you know, the numbers were going up. We had our peak in 2019, and then thereafter, 2020, we started to decline, partly because we lost staff unable to support them, and of course also the COVID pandemic. So currently, our team has only 1 doctor. We've lost, initially we had built capacity and had 3 doctors. We trained 1 doctor from being an MO to master's level. However, because we don't have posts in the ministry, in Mulago National Referral Hospital or Makerere, it has been hard to sustain the doctors and also the nurses. So we had 5 nurses, some retired, so currently we only have 2 nurses and 1 clinical officer and 1 social worker. And all these are supported by an NGO, the Palliative Care Education and Research Consortium. And even the doctor who is there, who is me, works part-time on a volunteer basis. We have been fortunate to be offered a full-time nurse in Chirudu Hospital, who is here. And also, now, we really thank Dr. Nakwagala. When we told him our plight, he deployed interns to us since May, and actually our patient numbers have gone up since then. And as of October, he has also worked with the nursing team. We also thank the nursing team and they've looked for all the nurses who have done palliative care training, especially at the diploma level. And now we have 5 nurses who start working with us. Each will do 1 day because they already committed in other areas. Will do 1 day with us. Once a week, there are 5, so 1 will come on Monday up to Friday, we'll have a different nurse. So we thank you very much, Dr. Nakwagala, for that very much support. Also, we're excited because recently he showed us the staffing structure, which shows that there will be a consultant in future, a senior consultant, medical officers. So we really hope that that will be approved at the ministry level so that people can be employed. When I train students, sometimes they get excited and they say, oh, this is a good thing, I would like to join palliative care. But because there's no career path, there's nowhere to go. They say, Dr. Namkwaya never employed. Eventually they think, I don't think I should join. So in terms of education and training, we've been training again since 2008. Majority of our trainees have been from the medical school, both initially Makerere, and now the Islamic University of Uganda. And those are undergraduates. And then we have from our department, internal medicine, masters in internal medicine, and other masters, family medicine, ENT, and obs-gynae. The undergraduates normally come for 1 week. They have a 1 week's lecture plus a 1 week's placement. But the master's students are now initially started with 2 weeks and now doing a month in palliative care. Those of family medicine and internal medicine. The others, obs-gynae, pediatrics, do shorter rotations. We also have a master's in bioethics students who come to see the ethical issues in palliative care. We have also had many international students come to have a placement here, and residents. We participate in teaching the BSc and MSc at Hospice Africa, Uganda. And we have also students who are doing a diploma in palliative care in Mulago who come to rotate with us. We've trained several link nurses. Now these are healthcare workers who work in the hospital, but who work in areas where there's high need for palliative care. So we work with the ward in charges, they identify those who they really think are interested in palliative care, and we give them extra training. So these provide the level 2 care. They see the patients, and if they are complex, they will refer to us for complex care. We've also trained pharmacists and allied health professionals and volunteers. There are volunteers in the hospital who come to help patients in practical care. These ones clean up patients, especially patients who don't have caregivers, they've also asked us and we've trained them, in addition to training our own volunteers. This picture, I put it in particular because this was our first class of masters in internal medicine. You may know many of them are now big people, cardiologists, WHO, yes. So this was our first class that we trained, and the other picture is the link nurses. And this is one quote from our first students, that the training made a big impact on them. They don't see a patient as a disease anymore, but as a person. And they are able to engage in difficult conversations. They consider when they are choosing investigations, and they see them as part of a family and do holistic care. And they say that was not like that before. We have also built capacity for our staff. Many of our staff at the beginning were specialist nurses, but without a degree, and we have trained, most of them have trained to get a degree in palliative care and 1 degree in social work. We had 3 masters trained, as I talked about, the one who had masters in internal medicine, one in social worker, and our nurse Florence has done a master's in palliative care, and 1 PhD, and there's also 1 PhD ongoing, which is about to complete. This person who is now doing a PhD is a nephrologist who is interested in palliative care. So she's doing her PhD in palliative care for renal diseases. In terms of research, we support research to be an integral part of service development. As you see, most of the plans we make are based on the data we get from the research. And we have a research agenda, and we are involved in training people in research. We have 3 broad themes of research from our research agenda, mainly related to patient and carer needs. And part of it has been the needs assessment, describing disease trajectories, and now using two steps of the analgesic ladder versus 3 steps, and information needs. Much of this research has been done by people in our team who are here. And then we have a strand on staff needs and also health system issues, and we've done some research on how we can use digital technology to reach as many people as possible in palliative care and follow up patients when they go home. And we collaborate with several people locally and internationally. We are part of the African Palliative Care Research Network, and our international collaborators from Europe and US and US. These are some of our publications. We have about 50 publications, and just a few of them here. My time is up, but this is the end of my presentation. Our biggest challenge is sustainability of the service, because none of us in the core team are employed by either Mulago or Makere, and we have lost the other staff, like Dr. Jack, whom you all know, has left. And we've lost the social worker, the masters in social work whom we trained. And many of the staff, because of the financing, currently work part-time, so we may not respond in a timely manner. And yes, we have challenges sometimes discharging patients who are dependent on oxygen because there's no home oxygen. So when we talk about our average length of stay, sometimes some have stayed. In Chirudu, we had patients who had stayed on the ward since we transferred to Chirudu in 2017. Some just died last year. So it's a big challenge. And also, home-based care is mainly for cancer. So when we discharge patients who have non-cancer conditions, it's a challenge because home care is difficult. They have to continue coming. I wish to acknowledge all those people. And thank you very much for listening.
Thank you very much, Dr. Namkwaya. I have sought permission for what I'm going to do next, and it was granted. And so I'm going to hijack Dr. Amanduo Jacinto, who is the former Commissioner of Clinical Services, to say something to us for 2 minutes, and then introduce our founding matriarch for the palliative care in Uganda, so that she too may say something to us in the next 10 minutes, please, before our keynote address. I was permitted to hijack you.
Now, this is real hijacking because I was enjoying the talks, but I think nonetheless I will say one or two things, but less than 2 minutes. Now, I think if you see me now, and you saw me many years ago, I think there is a difference. The difference is I'm older. And also, I move using a stick these days, which I never used to. So it means that I am nearer that side of medical practice. Yeah. Now, I think I'd just like to say a few things. One, the need for palliative care in this country is very big all over the world. In my active practice, and as head of clinical services, in fact, most of the conditions we manage in the hospital, our patients die. They don't recover actually. Dr. Nakwagala, not so. Whether you're a cardiologist, you are a cancer, but things are improving now. During our time, almost all the patients died. Unless if you did a Caesar, Caesar patients recovered. But the others, they will all. Number two, the medications were very few at that time. I think we only had the pethidine, which was used for surgical pain, and the other things were not there. Then number three, the senior doctor didn't want us to control pain. Dr. Okello was my teacher, but he's not one of them, the ones who were. So controlling pain was part of the medical care. But so I committed a bit of my time to palliative care development in the Ministry of Health, and I think I'm happy things are improving now because palliative care is very simple. It is not an expensive thing to do, and it is the way we do things which matters. Because we really have most of the things for palliative care here in which we can provide. I'm glad that Dr. Mwanga is here, and the instruments for delivering palliative care are available wherever you are, whether you work in IDI, in the Cancer Institute, they are there. And also, many of the medication were better than 20 years ago. Morphine is here. We have the other medicines which are there. Government has, palliative care has been trying to be as much integrated as possible. They are not. So we have the framework. I think as a country, we should take advantage to look at the positive side to do. That's our thing. Lastly, I would like to appeal to the doctors. I think doctors becoming a problem in handling dying patients. Either we're not prepared or we don't know. Maybe in the future, we should focus on that. How to manage dying patients. We don't know how to manage death. I've seen the result is we refer patients out. We have seen how many of our people who have died outside without saying a word to their family, which is not very good for our African culture. I think we should address that issue. Food health treatment, where is Dr. Nakwagara? Food health treatment for us, and even for our doctors have a role to advise government to say things. It is very sad that all our big people are dying outside. It's not good as a country. I think there's something we should work on. The other things, Dr. Moses has been given a platform, we should support him. I think that will be, we should support him so that palliative care improves. For those of you who are still in active practice, I think I admire you a lot. You do more than what was in the past. They're still on the way, a lot on the way, and we would like to wish that every Ugandan, every African, every person in the world needs to die in dignity, regardless of the status or anything. I think those are the things I want to say. I was to introduce Dr. Keller. Oh, Dr. Merriman. Yes, yes. Dr. Merriman, do I need to introduce her? The only thing I can say about Dr. Merriman, when I was in Arua, I got stuck with a patient. That was 1993, I think, 1993. There was a patient whom we could not manage, so I came to, by then I was a physician there, the medical superintendent. I came to Dr. Mbide, it was a cancer patient. So Dr. Mbide told me he cannot help me. With despair. I got very disappointed. And he said, but you go to Dr. Merriman, maybe she can help you. From that time, we have been friends. I call her my mommy. I think the rest is history. She's the founder of Palliative Care in this country. She has done a lot of things in this country. And I think she is successful because the government has supported her. I would like to ask you people who are in government to support the non-state actors so that we move together. Palliative care is such a big thing, you cannot do it alone. It's not like riding a bicycle. You must do palliative care in a group. And any person who comes with such good ideas of Merriman, I think we should support. I think the rest talks by itself. What she has done here, what she has done in this country. I'm also happy that many young people attending here. Dr. Noela is here, Namukwaya. Who are they? Now, the young people should come in because we're not going to be here for good. Tomorrow we shall not be here. Thanks very much. I thought I should attend this thing of today, and I think I've learned a lot. Thank you very much. Yes.
Thank you so much.
Thank you very much for giving me this opportunity. I would just like to thank the Palliative Care Association of Uganda and Malago for coming together on this, and particularly for having this in this room. This is the room where we first taught palliative care in 1994. Our first teaching was in this room, and we did not fill one row of people. And one of those people in that row was my first nurse, Rose Kiwanuka, who has had a wonderful journey since, through hospice, through Palliative Care Association of Uganda, and now in her retirement, she's doing so much for people in communities. So, you know, that was a wonderful time, and I think of the Davis Lecture Theatre. Everything has changed since then, but the Davis Lecture Theatre has not changed. It looks exactly as it did then. Yeah. And, you know, then it was Professor Kakande in surgery that invited us to teach palliative medicine to the medical students. And it was through him that we began that teaching. And it was in 1998 that it was taken over by the Department of Medicine. And then we passed it over in 2008 and Dr. Liz was with us for a while, getting trained, and really amazing person she was, one of the best people we've ever had at hospice. And, you know, to see you all together now today in this situation, and so many people from different departments who know about palliative care and understand that the person is more important than the disease that the person has, which was said by Hippocrates 460 years before Christ came. So he was a very wise old guy. And he was also the guy that talked about autonomy that you've been talking about today, about having patient autonomy, having them make their own decisions. So thank God you're all here together now, and I hope there's some medical students here. Next year, it'll be 30 years since we brought in palliative care, and some of you were not even born then. So here you are now, knowing about palliative care. So we thank God for that. And please let people outside know. A lot of people think we're there just to look after people before death. And that happened when we first came. They'd bring us patients and say, please look after them. And they were going to die that night, you know. It was really, really hard. You have to know the patient to be able to help them and to help the families. So you need to see them. As WHO says, patients should be referred as soon as they have a life-threatening disease. Okay? So that we can get to know them. And we're not just doing cancer in the communities. Remember, 57% of people in this country never see a health worker. They go to the traditional healers and things like that. So it's really very important that they know that they can get help from us, particularly for the severe pain. And the biggest gift that we've brought here and to Africa as a whole is oral morphine. And we made up this in Singapore when I was working in palliative care in Singapore. We made it because they didn't have a pure solution of morphine where we could titrate it against the pain. And we brought that first to Nairobi and then here. And you have really sponsored it to move out, and the government gives it free to everybody who is in pain and prescribed by a recognized prescriber. So please, don't be buying it from outside. The pharmacies are bringing in things from abroad and you'll pay for it. It's free. It's free as long as you've got the recognized prescriber. So thanks very much for giving me this opportunity. It's lovely to talk to you. God bless.
Thank you, Dr. Merriman. The impact of training and teaching new things is important. I especially like the very quote you used from the MA student. If you look at the pull-up banner for Makere and Mulago, the bit that says, I don't avoid difficult conversations and I don't order unnecessary investigations. I see them as part of a family. I do holistic care. It was not like that before. So thank you. Now, moving on to our keynote address, I have the pleasure of introducing Dr. Kello David, the Executive Director of the African Center for Global Health and Social Transformation. He will be speaking to us on alleviating pain and suffering among patients with serious health-related suffering and approaches for community engagement. Briefly, Dr. Kello is a public health physician expert with more than 40 years of national and international experience, currently serving as the Executive Director for ACHEST, an initiative that has first-hand experience in planning and implementing health and development programs in Africa and at an international level. He spearheads health systems work geared towards health promotion and disease prevention. He has, of late, led a cutting-edge study on the role of intersectoral collaboration in healthcare and how it could be used to fast-track achievement of UHC and SDGs. He recently retired from WHO, where he served for 18 years under different portfolios as the WHO country rep in several African countries, including Kenya, Nigeria, Swaziland, South Africa, and Zim. Director of WHO Cluster on AIDS, TB, and Malaria for the Regional Office for Africa, and then coordinator of WHO Inter-Country Support Team for East and Southern Africa, based in Harare, Zimbabwe. And also as the regional advisor on health research policy, coordination, and development. Dr. Kello has practical skills in policy analysis and high-level dialogue and negotiation techniques, as well as outstanding leadership, strategic thinking, team building, and management of results skills acquired through targeted UN senior staff training and long experience in the UN system. Prior to WHO, Dr. Kello spent most of his earlier professional life in academia as senior lecturer at Makere University Medical School, where he was engaged in training undergraduate and postgraduate medical students, including my dad. Thank you. He also spearheads health systems research for the Uganda Ministry of Health and has, in the process, acquired field expertise in research to practice identifying and adapting best practices to specific project contexts. He's a graduate of Makere University, and of Newcastle University, Australia, with a Master of Science in Epidemiology degree. Surely that deserves a huge hand clap as we welcome Dr. Okele David to give us our keynote address.
Good afternoon, everybody. Good afternoon again, people at the back. I'm glad to see you here, Dr. Alwavi, Dr. Mandwa, of course, Dr. Nkwagala Nyosibu. I'm glad to see you have grown up now, you are in charge. Coming here, it's a bit nostalgic for me. I was a lecturer in this hall many years ago, over 20 years ago. And when I come back, I see very new faces, people I don't know, people I never met before. Dr. Mwanga, welcome. You are representing the Ministry of Health. This is a very important discussion. And I must confess, I'm not going to talk to you about pain relief. I think there are people who can deal with that better, people in hospice. What I want to talk about is community engagement. Community engagement. Most of the discussions I've had here is about hospital care, clinic care, and so on. We have not discussed the issue of community engagement. Our patients come from communities. When they die, they're buried in communities. And it's important that we see this as part of care. Care is not just given by doctors and nurses. Everybody gets involved in care. So please, excuse me if I disappoint you. I'm not going to talk about what you call pain relief. I think pain relief can be handled by specialists who are here, and if you want, another time can be devoted to that. Now, let me walk you through this. Since I came back from those international engagements, I'm retired, but I'm not tired yet. Dr. Mandwa, I'm not tired yet. I may be retired, but not tired. I can still provide some knowledge. I can still engage in public health issues. I start with the issue of what is community engagement. I think it's important for us to be on the same page. The word community is a broad term and used to define different things with different people. But simply, it's about any group of people living together, whether they are stakeholders or are interest groups or citizen groups, religious groups, footballers, and so on. They are all different communities. Health workers, different communities, headquarters of the Ministry of Health, medical school. You are your own community. And you have your interest, you have your challenges. A community may be a geographical location, a community of similar interest, a community of affiliation or identity, industry, sports, and so on. But what is community engagement? It is a strategic process of working with groups of people to identify and address issues affecting their well-being. Very important, and it's important for us to understand that. Next slide. This slide is an attempt for me to describe aspects of community engagement. Different things involved. You have education going on in the community. You have consultation going on in the community. You have participation. Communities are participating. You have partnership being created in the community, and so on and so on. Dialogues and what have you. So there are different aspects in the community, but they are all community engagement. To exemplify the story of community engagement, let me talk about the community engagement strategy for COVID response. Dr. Mwanga, you are here. I don't know if there has been any strategy developed by the government, the Ministry of Health, to do with community engagement. We've had many epidemics, we have many problems in the country. The only time we started talking about community engagement was when we had COVID. COVID was a serious problem. The whole country was affected. Everybody was scared. Government was involved from the highest level. The president was giving lectures almost every week about COVID. We were scared. We were really scared about what COVID would do with us. So the idea of getting communities to take charge of their lives became very apparent. That's when the government developed what is called community engagement for COVID response in Uganda. And I'm going to use this to exemplify, to talk about what are involved in community engagement. We were very central to this. In fact, we drafted the strategy and took it to the ministry to adopt. It's an important document, and we can use it to deal with all other community issues in Uganda. I just want you to know. What is the background? In September 2020, the National Task Force for COVID Response, under the chairmanship of the head of state, developed this strategy. And developed the strategy, and a subcommittee was created. A subcommittee on community engagement strategy was created to deal with this problem seriously for the whole country. And the committee sits every week under the chairmanship of Professor Maswa, really talking about what's happening deep in the villages with COVID. And everybody got engrossed into this. The objectives, I'm moving faster than you, the objective of the community engagement strategy for COVID response was that all people in Uganda are aware, empowered, and are participating in the prevention and control of COVID outbreak, both as a duty and a right, using existing structures to the extent possible, and also using existing resources to the extent possible, especially at community level. Because the monies you were collecting here, Dr. Mwanga at the headquarters, deep in the villages, it was not reaching much. So we had to help them to deal with this using the resources they have at home. Now, the guiding principles of the strategy are empowering individuals and communities based on the presumption that good health starts at home. Good health starts with the people at home and is created by individuals, their families, and their communities. That's where good health starts. It is supported where necessary by technical support from professionals like yourselves. But also, it is important that we respect the right of individual communities, the right to be informed, the right to be consulted, and the right to be empowered. This is important. That is really the gist of the issues in community engagement. The strategy that was developed in that document I showed you was to strengthen the existing community health systems for integrated, people-centered primary health care, to ensure that infections are minimized in the community, to ensure that people who are sick are identified, they are tested and treated as much as possible, or referred to the health facilities where need be, or for rehabilitation if it was needed. So those were the strategies that were spelled out in that booklet I have just shown you the cover page. To operationalize this strategy, government issued instructions to all districts to establish COVID-19 task forces at all levels. Task forces were issued and created across the country, at district level, at sub-county level, at parish level, and in villages. That is what the strategy instructed. The village COVID task forces were mobilized, and they mobilized communities as well to raise awareness about COVID and to ensure adherence to what the ministry called standard operating procedures. There are lessons here I want you to pick as we go on for hospice and palliative care. Every month, the village COVID task forces and the village health teams would meet and discuss how they are dealing with COVID across the country. This is what was happening. And there were structures that were mobilized and put in. This is in the book also, the strategy that the ministry developed is a small print, but I just want you to know that different levels of structures were mobilized. At the village level, the LC1 was very critical, and he formed a committee that became known as Village COVID Task Force. And they had many responsibilities, including community-based surveillance, case detection, home-based care, and all those things, responding to other health needs as they arose in the community. Very strong. This was really something we had not done before for any disease outbreak in Uganda. Even when we had the peak of HIV here, we did not go through this. It only started with COVID because we were scared. At other levels, at LC2 level, LC3 levels, district level, there were committees formed that were mainly supporting the community level systems. Very important, and it worked very well in our view. Now, let me talk about this other strategy from the ministry. It is called the role of village health teams, VHTs. They're common, they're not nurses, they're not doctors, but they're there in the communities. Well spelled out, a strategy was developed by the ministry and clear guidelines of how VHTs work. VHTs, up to now, have been working as volunteers. They are in the villages. If you go to your village, you will find somebody called a VHT, and they are volunteers. They're not well trained, but they really help with dealing with some of the problems that arise. The model, if you go to next slide, please. The model, as I said, started around 2001 when this strategy was built. Their role is to support mobilization and sensitization of households on issues of health across disease prevention and so on. They are very important people. They bridge the gap between households and communities and health facilities and health centers. They are the bridge. They're like the go-between to report what's going on. And they facilitate, in some cases, data collection. They collect data on issues affecting communities. At this time, they were collecting data on COVID very effectively across the country. Now, I will now tell you our experience as ACHEST. ACHEST, where I work, we were contracted by JICA, the Japanese International Development Corporation, to implement the ministry CES strategy for COVID response, to implement to scale, to try and see how we could implement that strategy to scale. And we were invited to the national task force teams to really see how that strategy can be operationalized across the country. So we identified pilot districts. We identified 4 pilot districts where we worked intensively with the VHTs, with those task forces I was talking about, the district of Amuru in northern Uganda, the district of Busia in eastern Uganda, the district of Mukono, and the district of another one, Busia. We went there and started implementing this. And the support we gave to these districts included a number of things. For each district, we trained a group of 160 VHTs. We trained them how to detect COVID, how to manage COVID, how to report on COVID. And they were trained also to collect data. And we gave them a number of equipment to do their work. We gave them bicycles for movement. We gave them a backpack for carrying sanitizers, for carrying a cell phone, for carrying a data recording tool, the village health register. And these people are moving across the villages from village to village collecting data and looking after sick people at home. Of course, when there was a problem, they would refer, and they were supported by the health centers next to them. The objective of the pilot project was to implement the CES to scale and also to learn lessons for scaling up the project, the activities of community engagement throughout the country to roll out that program. The project worked with, existing structures, district authorities, the parish level people, and the LCs. Archest undertook monthly visits to these 4 districts. Every month we were going out to these districts to really help the district teams, the DHOs and everybody there, to make sure they were responding to COVID appropriately. Now, there were also other things we did before. Before COVID, we were also implementing issues on how to engage communities. And in fact, the community engagement strategy that was developed for COVID was based on previous work we were doing. And we used it to really help the government to come up with this strategy. So in my view, the work we've been doing on community engagement before COVID was really like we were predicting that COVID would come. Because all the things we were doing there, we now carried it into the COVID response and was very instrumental. So, achievements. A number of achievements which I can share with you. For example, we found that all health centers in Uganda monitor what is called result-based financing indicators. All the indicators that are being monitored by health facilities where we were working improved dramatically. Things just changed, not because of any major investment put in place, but because the communities were mobilized. Home-based care and some of the things that were going on in the communities got better, people understood it better. Hygiene, for example, and sanitation improved a lot. And the model homes, there was something called model homes that we started promoting in the communities, and the model homes became part of the community livelihood. The VHTs became more acceptable, they became part of the health system, they were more respected, and people really loved how they work. And let me show you some results that we are able to share with you. Next, please. This is something we monitored in Ngora district. The ANC visits, delivery of mothers in antenatal clinics, DPT, immunization, improved. The blue one was before we got involved, and the yellow one are things that are really improving when we were there, and things continue to improve dramatically. Next. In Mukono district, you can see family planning activities got better because mothers were mobilized, families were mobilized, things improved even beyond COVID itself. And also the type of the immunization coverage in Mukono got better, and it's getting better by the day. Next. In those villages, we promoted sanitation. And every home where you go, they have what they call tippy taps, where people, during the peak of COVID, before you go to somebody's house, you have to wash your hand at the entrance of the home. And people, everybody who walks to that house, there was a jerry can that has water and soap. So you wash your hand before entering the home. Good practice for preventing COVID, and can be applied also for preventing Ebola. This is a model home in one of the villages in Amuru. Using local materials, things just improved because the VHT started promoting this agenda of good health, better home care, better facilities at home, and so on. So in our view, this is something we need to look forward to. Lessons learned. We learned that organized communities are capable of owning and taking responsibility for their own health and achieving social cohesion as much as possible. Organized communities also improve relationships between communities and health facilities. Usually, sometimes there's a bit of tension between health facilities and communities. But with this group, things got better. But equipping, training, supervising, and paying VHTs is essential for them to perform their roles effectively. If you want them to get involved in palliative care, you need to find a way of incentivizing them. District health performance generally improve when you visit them regularly. We are going to the districts every month, and these people really felt they were being supported. As I come towards the end of my presentation to you, how can this experience be applied to hospice and palliative care? I think it's important for me to go slowly here. First, I think we should try and mainstream hospice and palliative care services into the district and community health systems. I worry that sometimes you discharge patients to a home and you keep visiting them as individuals, and you have not incorporated this as part of the district health system, as part of community health system. I think you need to incorporate this idea beyond just patient and doctor, patient and facility level. This is important. We need to create community awareness of what we are talking about here, about palliative care, about hospice. Community as a whole, they are very concerned about this. If somebody dies, it's the community that bury. It's a loss to the community. And they are affected in different ways. So it's important that we sell this idea to go beyond individuals. And this is not just a problem of Ministry of Health, it's a problem of the community. They need to get aware, they need to be trained, they need to be taught on how to deal with it. Integrate hospice and palliative care into home-based care. You said that home-based care is currently just being offered for cancer patients. I think we need to know that the village health teams are already doing home-based care, and we need to help them deal with all aspects of palliative care and hospice in their setup of home-based care. It's already happening in some districts, probably not all over. But for them to get involved, they need to be trained, they need to be incentivized, and they need to be given equipment to be able to do it properly. If you're offering oral morphine and all those other drugs that people use, you can use the VHTs, because we don't have a lot of nurses and doctors to spread all over the country, but the VHTs are there. They can be used, they can be engaged to get involved. Finally, there are new developments happening in the Ministry of Health and in this country that we need to take advantage of. The Ministry of Health is developing a new community health strategy. Probably it's going to be launched very soon. And we need to be aware of this and begin to inject the idea of hospice and palliative care into the minds of Dr. Mwanga and his team, Dr. Opentho, to talk about home-based care for terminally sick people as well. It is not something out of control, out of their perspectives. Also, the new health policy of the ministry is very loaded with issues of community health. So this is not something totally out of focus. It is part of our responsibility. We in Achest are also talking with the Minister of Local Government, Minister of Education and Sport, as well as the Minister of Health, to integrate community health programs and work with the VHTs in Pillar 4 of the Paris Development Model. I don't know how many of you know about Paris Development Model. It's being sung every day, but a lot of it is about creating wealth. It's about creating money for the village, the circles, and so on. There is a section under Section 4 called Pillar 4. It is social services. It has not been developed at all. There's only a line or two written about it. And yet, healthy people are the ones who make wealth. If they are sick, they cannot make wealth. Your health is your wealth. I think we should, as a group, talk about improving social services under Paris development model. It is not happening yet, but I hope it will become a subject of discussion with the Minister of Health and the team that are responsible for Paris development model. It's not just making money. We need to do more than that. Finally, next. I know we want to touch lives of people. We want to heal communities and transform society. For me, this is a commendable agenda for palliative care movement. It is important. We need to emphasize in both the social context as well as the broader environment in which we work to address this agenda. This agenda is very important. We cannot leave it to just one doctor talking about it. If the doctor who is in charge of this program goes away, what will happen? I think the ministry should really prioritize this issue of hospice and palliative care. People are born, people will die. And we are going to interact with all kinds of environmental problems. We must find a humane way of helping our people succumb to what they go through. I thank you very much.
Thank you very much, Dr. Keller. Another round of applause, please, for our Chief Keynote Speaker. The next, please, I'm very cognizant of the time and also request that you lend us some more minutes so that we can get into the Q&A session and a mini discussion with our panel and address any questions that we have raised, both that will come through here and also online. So I would like to invite our panel to come to the front. Some things haven't changed. So these are our places where we shall sit and respond to the questions from the team attending. Dr. Alwabi, Dr. Nakwagala, Dr. Elizabeth, Dr. Kello, you can sit where you like. I'll have a roving microphone to take any questions from the room. In the meantime, I have over 5 questions online, so I'm going to request somebody with, good, thanks. It's off, just switch it on. We have a question there. We'll take 1 in the room, and I'll read 2 online, because they're quite a number.
Good afternoon, everyone. My name is Nalima Leila, one of the palliative care link nurses. When Dr. Nakwagala was giving his presentation, I got to remember of a certain scenario that I encountered on the ward. It was over the weekend and I was nursing this patient. Morphine prescribed 10 milligrams, 10 meals, and he's taking it 4 hourly, and he's having their bedside chat 6 a.m., 2 p.m., and patient was doing well. And was also given an adjuvant. I remember it was amitriptyline plus paracetamol. So you could look at when you look at pain management, the patient was well covered. But the patient kept on complaining of pain. So we had to get into a family conference to explain to the patient. The patient was not in denial. He confessed he knows his disease and is aware about the cause. But the patient was not responding well when it comes to pain control. So on Sunday, what happened, the patient told me, Musao, thank you very much for your time, but sincerely speaking, I have taken long without praying with my reverend. But being a Muslim, I couldn't do much about it. So, lucky enough, my in-charge was on duty. She passed by and informed her. So she called the church, the Mulago church, and the chaplain was there in the afternoon. Mr. J.B. on Monday was a different person. We had titrated his morphine to 10 mils from 7.5. On Wednesday, he was back on 5 mils. By the time the week ended, it was my first time I saw a cancer patient getting off morphine. That is number one. Number two, Dr. Nakwagala still was complaining about the nurses we have of these days, and I will admit. But whoever policymaker is in this house, let us give palliative care more time back in the training schools. I will confess I was this kind of person working in Cancer Institute, and you have this big fungating wound. You're new in the field, newly qualified, but when I got into the link nurses class, one thing the palliative care team will change about you is your attitude. You get to understand that I'm nursing patient X, not nursing the ward. Only that, you'll find yourself giving more attention to some patients, and some might think you're doing a disservice to them. But if we want to change the nurses' attitude, let us give palliative care more time. And this is for Dr. Namkwaya. Do you have refresher courses for training the link nurses? Because I loved, up to now, I know how to prepare mouthwash. We use it so much in Cancer Institute, but I prepare for patients that I interface with. If I don't interface with those patients, they miss out. And there is no wound I will fail to dress, however bad it will be. I'm not on the ward, but even if I find them on compound, I grab them, take them to my unit, and do the dressing. So if there is a refresher course, I'll be happy to come back for it. I might have lost palliative care along the way, but at least I still have that card. And for the policy makers, please let us have the religious leaders get on board. It is high time we got a sheikh, a pastor, and a reverend father work with us. Because I couldn't do much for this patient, but when the priest
Thank
came,
you.
everything was
I apologize, I've interrupted you. Thank you. So, would you like Dr. Nakwagala to respond to your comment, and then Dr. Namkwaya? Yes? It was the same comment as a comment. The reason there was a question on, she had a question on whether or not nurses can have a refresher course. Was that a question for Dr. Namkwaya?
Thank you, Leila, and for encouraging us that our training helps. So, yes, we haven't had yet refresher courses, but it's something we are discussing, and since now you've brought it up, it's something we are going to take into consideration to find a way of doing refresher courses. Before we were giving you mentorship, but I think you're among the first trainees, so you probably, yes, we shall think about it. Thank you.
Thank you, Dr. Namkwaya. Online is similar concerns being expressed. So the first question was that some of the palliative care needs that are not yet well addressed are psychosocial and spiritual needs. How can these be addressed? The second part to this is some of the nurses, clinic officers, and doctors are still harsh to palliative care patients. How should this be mitigated? Who wants to take it on?
Now, I wanted to make a comment on the earlier issue of the policy changes. I think we need to go there, but not only just for the spiritualists. What I would propose is that we need first to do some evidence-based research to define what the problem is. I did mention in my presentation that we need to have, for example, medical anthropologists. These are people who study culture dynamism and culture changes and how they impact healthcare changes. if you think that, for example, circumcision among the Bagisu promotes to bad health practices, you will not just come in and say, stop, do this. You need an anthropologist to guide you. Study the culture, study the practices. Why are things done the way they are done? So I think we have a very tall order. For example, we've been having a problem of policymakers not understanding or not aware of the need to recruit social workers, medical social workers. We have issues with nutritionists. You know, we don't have nutritionists in medical practice. So all these issues need to be brought on board. Now, within these needs, I think research can be done to define what the need is in reference to palliative care. And I think that can be quantified. And then by the time we go to public service and Health Service Commission and say, we need this caliber of people, people would have defined what the need is, and if you're going to have a social worker, for example, in every district hospital, you need to really sit down and quantify that need. I think the Dr. Mwangas know how to do those things. That's what they are there for. Some of us, we just know how to hit E. coli when we come across it. But I think that's very important, and we need to begin those processes. And then we can have the change that can lead us to that. Then on the issue of the harsh clinicians, I do teach bioethics at university level, right for all types of medical care professionals, right from year one up to postgraduate. And I think through some of these processes like teaching and mentoring, we can have an impact on people. There's definitely no role, there's definitely no model in which a healthcare provider can either laugh or deride or mistreat a patient. It's not there at all. And the principles of the profession are very clear. We have ethical codes, we have foundations with international, whatever, everything is set. And we do mentor people. So those mechanisms are there. Some of them, however, would need corrective measures. So we have committees in hospitals and in public service that correct people who do wrong things. There will always be some, the president calls them what? Kaukumi. There will always be some weavers that need to be corrected through relevant committees within the hospital. But I think the focus should be on us looking at our client as serving with honor, so that we serve with joy in our hearts. We go back home and we feel like you brought some smile on your patient, rather than, we had this issue in the Kawempe where, in Mulago here before they went to Kawempe, where midwives developed a habit of slapping the mother so that she can push the baby. And then the slapping moved on to abusing. Was I there when you did it? All sorts of things. And this had to be stopped, you know. We had to train them and say no. So people can be trained, people can be mentored, and there can be a lot of progress.
Thank you very much, Dr. Nakwagala. We'll have a question from the room. Yes, please.
Thank you very much, the organizers. My question is going to Dr. Okello, and I appreciate that you brought out the engagement of communities, which is very key because these are the end users of these services. I work with the Initiative for Social and Economic Rights, and I am a community outreach officer. So I am so delighted that you brought this up. Community engagement is very key when we are providing services, because we expect them to provide feedback, and I don't think we have community people around here that would bring out, you said evidence-based, we would have maybe community people providing evidence, maybe their stories about what they went through. This would be very good for us. So going forward, I don't know how we are going to engage communities. What platforms are we creating into communities such that they have platforms for them to share what is going out there. And one of the things that ISA did during the COVID pandemic, personally, I wrote an article about meaningfully engaging communities, because we have community advocates in these communities where we work with, and they were giving us feedback about what is happening in their communities. And one of the recommendations we are giving about the VHTs in the communities, using those local mechanisms, the LCs, the health unit management committees, because they are down in their communities. So I think we should target these other mechanisms within communities and create platforms for them to participate meaningfully. Thank you.
Thank you very much. The panel seems already sold. I wonder if Dr. Kelly would like to say something.
I'm glad you've talked. That's very important. And where we have worked in those 4 districts, the platform is there. Every month, there is what is called a community dialogue session, where the entire community comes together from that village under the LC1. They discuss their issues, they have their fora, and they talk about what is working well and what is not working well. It is there. And at the district level, the district teams also hold monthly meetings with members of their team in the field, and they bring community workers, community extension workers, and they discuss their issues. I think it's maybe a new emphasis that is being brought up, but if we ignore the communities, we are in trouble. We need the communities. They know what the problems are, and they also have suggestions on how to deal with issues. The VHTs that I talked about and you refer to, most of them are still volunteers. They're selected by the communities. They're given the authority to talk about their problems, but on a voluntary basis. I think if we want to up the game a little bit, I would appeal to the government. The government is talking about choose. Choose is your agenda, but you have to train choose. And there are different cadre of people. Why not use the people who are there already and give them some incentives? Not much. Sometimes just giving them a bicycle. And if you give them a bicycle and equipment to work, they're very happy to do it. And I think that discussion is going on in the ministry. So yes, you are absolutely right. Let us look at what the communities can do. And all these issues about religious leaders are part of the community. They also help patients. When people are sick in the village, you have a cancer patient, the religious people go and pray with them, and they are perhaps much better in counseling than our medical doctors and nurses, because they deal with society, they deal with people, and they deal with the whole body, spiritual and physical body. And I think let's learn to engage religious leaders more. A long time ago, when I used to practice in Mulago, there was a department of social works that was there, and they were employed by the Ministry of Health. I don't know what has happened, whether they have been phased out or they're usually seen as not a priority. I think the discussion here is beginning to point to the need of the ministry to really employ social workers. Employ them. Employ even priests and imams are part of social work system. And they may not require a lot of money, but recognizing that they are doing a job and that they're paraded as part of the medical team of Mulago Hospital will make a big difference. So I totally agree with your comments, and let's push the agenda. I don't know whether there will be resolutions from this meeting, but this is one of them.
Dr. Okello. I believe Dr. Manga will have plenty to say at some meeting somewhere, not necessarily here. So we'll take another question online. I'll combine them because they're quite related. The first is who qualifies for palliative care? Then the other is how can a patient be referred for palliative care? And the third is, are the palliative care services upcountry or in rural areas?
Okay, thank you very much. Maybe just before even I answer that, there's a question about clinic officers and medical people still being rude. Also, we have to think about supporting the carers of care. I mean, the patient, health professionals who care for others, because they get burnout, then they get compassion fatigue, so they don't care whatever you're going through. So it's good to care for them, and some people, maybe they are going through that, and others just don't know how to empathize. So empathy is something, it's good to teach them how to self-reflect and put themselves into the shoes of a patient, then they can know what they are going through. And also the other thing was about psychosocial assessment not being done. Management is poorly done and spiritual, and the first step to any management is assessment, and I think it would be nice to emphasize those assessments for patients. I remember in medical school, when we teach, the students will assess when they are still with us. When they go to another unit, they don't. So we've had a consultant who insists on spiritual support because he's passionate about it, one of our professors. So, and now that is taking on. So if wherever they go, people insist on those assessments, that will be helpful. So who qualifies for palliative care, and are there palliative care services upcountry? Palliative care services is the easier one. Mr. Mark Mwesiga, the head, was showing us the map of Uganda and where the palliative care services are, and they are scattered all over the country. Majority of the areas had palliative care services, except those areas where it's white. I think Palliative Care Association can help maybe to provide a list of providers and phone numbers. We have some of them, but our list is outdated now. But that will help you to check where their services are. Some areas they don't have. I've just seen on the forum, Luwero will have soon. So many areas it's possible to get palliative care. But who needs palliative care? Anyone with a life-limiting or life-threatening condition. So especially chronic conditions which are not reversible and will limit someone's lifespan. Those qualify for palliative care. Cancer and all the conditions I've been talking about, organ failure, which can be liver, respiratory, heart failure, all those need, especially as when they start being irreversible. We have conditions that, like sickle cell disease, still that is life-limiting because, as you know, they will not enjoy a full lifespan. And also now life-threatening conditions, sometimes we have people in the intensive care unit, we are called. A patient has come in with severe sepsis. They are not very sure this patient is going to survive. Yes, initially it was an infection, but now it comes to a point where they don't know whether this patient is going to survive or not. The chances are 50-50 or 30-70, so these also qualify for palliative care because there'll be a lot of family distress, patient distress, and we can help in the psychosocial, spiritual domain to support these patients. How do they get referred? Yes, most of the time from hospitals, we contact those service providers. Palliative Care Association, again, has contacts for those people. So you can call directly to those people in the different areas. And yeah, the majority of people from Kampala go to Hospice Africa, Uganda, and the contacts are available, again, at the Palliative Care Association of Uganda.
Elizabeth, we'll have two more questions, yours and hers, and one here, and we close the Q&A. Oh, all right. We're trying to catch up with time. We'll allow
Thank you very much. Prosi Chebeta, my name's. I am a medical social worker, Mulago National Referral Hospital.
You're welcome.
Thank you. Dr. Okello was asking whether the department is still there. It is there. Though we are very few in number, Dr. Nakwagala knows that. I am also a member of Palliative Care Association of Uganda. I became a member even before I joined service. I want to request Dr. Elizabeth, please, when you have your refresher trainings and what have you, please invite the social workers so that they can be part of it. This knowledge is very necessary for all of us. I remember there was a time I was called in medical emergency. It was a weekend. I usually don't work over the weekend. But the doctor was like, please, you have to come. It's a matter of death and life. I asked him, what is it? He's like, please, come. There is this old man whom we know we cannot save. He is going, but the family is insisting, we want to go to ICU, blah, 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 blah. Come and talk to them. I quickly swung into action. I came, we talked with the family, and at the end of it all, they got ready and prepared, and in the night, the old man passed on. They called me, they were like, thank you, because the doctor was like, they are going to spend a lot of money, which may not be worth it. I thank God that indeed they listened, we talked, and everything went on well. So, Dr. Elizabeth, please, my colleagues need this. I also need to grow more in this. Thank you very much. God bless you all.
Thank you so much. I can guess you have nothing more to add.
Hello everyone. My name is Daisy and I'm from ISA as well. So recently, ISA was holding an initiative for the rights of the people with disabilities. And my question goes to the panel. How well have you included these people? And when they come to you with this particular problem here, how do you understand them? How do you communicate with them? Have there been measures you've taken to include them? Have you taught them the basics? And yes, we understand that it's the role of government to provide for these people and to provide as public health care units, but then if you don't come out, then how will the government know? So my question is, how have you included them?
Who would like to take that on?
The disability issue, Mark would be the right person, but I would say that the Palliative Care Association of Uganda is working hard to include the people with disability. Mark has the right information, but I would say the little that I know, and they're trying to train healthcare workers to ensure that at least they address the issues of the disability. My question, I don't know whether it's a question, but I want to say that I had Dr. Nakwagala say that patients are brought into hospital to die. I would say yes. There are a number of issues. There is an issue of culture, because in the African culture, we want to see that we do everything until the end. But also we fear death, and somebody dying from home becomes a taboo, and it's like you've not cared. But all this is about sensitization. Palliative care is everybody's business. We need to work together to sensitize communities, to ensure that people understand, but also the healthcare workers, because as you rightly put it, we don't know how to communicate with the people who are dying. We don't want to communicate with the family members, and then we hide information from the patient and we communicate with the family members thinking the patient doesn't know, and yet they know. So really, the bottom point is sensitization, let us sensitize each and everybody at each and every level, and then probably we will get there.
Yeah, I just wanted to share one or two experiences. One was a 73-year-old man who was brought into my care. He had CA prostate, diagnosed, but not disclosed to the patient. And the reason why the sons, who are in their 40s and 30s, hadn't disclosed, they didn't want him to know. They said he might commit suicide, he'll feel sad. So they brought the patient to me for management. You want us to manage your dad, but don't tell him that he has cancer of the prostate. So I took a deep breath and I said, this is a tough one, because my only work was to refer the patient to Uganda Cancer Institute. And I have to say the word Cancer Institute. So then how do I do it without doing it? So as I was still trying to take a breath, the patient chased the sons out of the room. He told them, please go out, I want to talk to my doctor. And then out of the blue, the patient goes into a laughter. And I didn't understand. It was like I was in a movie now. Now the patient is crying. I was trying to gather my strength to break bad news. The patient was just laughing. I said, why are you laughing? Then he tells me, have you also been deceived? I said, deceived about what? See, these sons of mine are busy trying to move me around from doctor to doctor, and they are hiding the fact that I have prostate cancer. I said, now things are, and it was a very jovial man. He said, they think I don't know. Eh? I know everything. And now I got more confused because they were going to come back in the room. I got more confused now how to handle them, because now they became the bigger problem now. So it's right that really we shouldn't take patients as fools, as idiots, as people who are down. And this man didn't go to school. He was just from the village. And he knew it all. And what I did was I gathered my guts, and I now broke the bad news to the sons. That this man knows everything. And they also burst into laughter. And then I saw the son exchanging faces with them, and they were saying, okay, you see, all along I knew. But the joke I want to end with was sometimes it's difficult to counsel younger people. So one time I was called to talk to some young people about abstinence from sex before marriage. And unfortunately for me, they were medical students. So the talk began very well, and somewhere in question and answer, one of the students put up his hand. It was a young boy, excuse me, Mr. Presenter, can you tell us about the dangers of disuse atrophy? So I said, well, ABCD. Now, you're telling us about abstinence? Are you really serious? That's when I discovered I was in very hot soup. Thank you for listening.
My attention has been drawn to an important subject. Who is caring for the caregivers? I think we should talk about this, and the ministry maybe needs to take note of this. Who is caring for the health workers? During the peak of COVID, there were health workers who were confined in the COVID treatment center for hours, for days, sometimes not eating. They are afraid they don't have proper personal protective equipment. They're fearing to get sick themselves. but ethically they must give care. Now we have Ebola. Health workers ethically cannot run away from patients. They give care, but they're also afraid to be contracting the problem they're handling. And I think it's a subject we need to talk about. In my view, the first people who should give care are your fellow colleagues. If you see your friend is getting burnt out, I think as hospital administrator, as head of department, you should really start to say, I think you need rest. I think you should go and have rest and get them out of these long hours of working and give them the necessary support they need. In the UK, I don't know if you followed, during the peak of COVID, if you come from Kamucha and you're going back in the evening, the whole community of Kamucha would stand by the roadside and clap for you, and really clap hard. And these people live in flats, and it became like a routine. It was really well received by health workers. So I think it's a subject we should talk about. Who is caring for these doctors who are giving palliative care? Do we really care? We see it as their employment. It's more than employment. It needs a heart. You need to be committed to it. And we need to help them to cope themselves. Many of them also are burnt out. They're anxious. They're fearing to deliver messages to patients. So they need help. So I wanted the ministry people to take note of this. Thank you very much.
Thank you, Dr. Kello. The ministry is having quite a bit of questions to respond to, and it's 25 to 5. So this is what we'll do, yeah? Let's agree. I have like 5 questions here. I'll take 2. I'll take 1, and then we close. There is so much to discuss. Maybe palliative care, you need to give this more than just 2 hours slot. There is so much, and it's all important. And now in the face of Ebola, care for the carers has returned in our faces to say, what have you done to prepare? All right, so here we go with the 2 online. There is lack of national palliative care policy that has greatly affected recruitment of trained palliative care professionals. What's the take of the ministry on this? Dr. Mwanga, I'll bring this over to you. Related is, I wonder if there are pre-Western case management systems that can be built on. Are there any students or literature on African approaches to terminal illness management? Yeah, that will be for you, Dr. Nakwa. Thank you. And lastly, thank you, Dr. Kello, for your elaborate presentation. You talked about the need to integrate VHTs in palliative care services provision, especially in the community. For example, availing them with drugs like morphine. Won't this pose a problem of misuse and addiction due to improper handling of such Class A or restricted medicines in the community? So there's quite a bit of, and already there was somebody that was meant to respond to another question. So let's start with Dr. Nakwagala. Then we come this side.
So it's very clear that before the colonials came to Africa, we had healthcare systems. Very obvious, you all know it. It was just different from the Western approach to healthcare. A lot of these healthcare systems are still present, a little bit modified, but the discipline that deals with this is what we call medical anthropology, which is a very known course, which some of you can go for. I think I know of only one medical anthropologist in Uganda who must be overwhelmed by the work, but that's the area. Maybe in terms of policy, the ministry could develop the field of medical anthropology. Now that we passed the Complementary Medicines Act, one wonders how the heck is it being applied? did they just say, go do the hubs? Did the ministry put up, how is it being implemented, Dr. Mwanga? I'm sure the act is already operational. But how is it being implemented and how is it integrated within the formal systems? But the discipline is called medical anthropology. Training institutions like Makerere can put up those courses, Mbara University or whatever, or people can be trained elsewhere and the discipline can grow. But we seriously need to, as researchers, we need to look into all these areas, medical social workers. You need to define for us what is health service delivery in an African context. Many of you know, for example, the issue of the issue of the attendant, who is normally a female. That phenomenon of the attendant who looks after the patient is an African thing. You go in a university, a hospital in the US and you don't see the attendant. You see documents, you see a lawyer, you see a bank statement. Those are the attendants. Here we have the attendant who is the judge, the daughter, the whatever, the cousin. Is it something we should throw away? Is it something we should celebrate and build on? We need evidence to guide us. When we come to palliative care, I'm sure palliative care team must be happy with that person called the attendant. He becomes a very important person in the delivery of palliative care services. But you'll advise us, Liz, have these things been documented? Have they been characterized from a palliative care aspect? Has this attendant's role been academically? I'll ask you to comment.
Well, there's some research. Last year or 2 years ago, we had a student who came to our unit, and as we were talking about what caregivers, the effect of caregiving, she got so interested, and there were these small grants from Makerere. She did a research on experiences of caregiving. That's the research I know she's about to publish it. But I think much more is
for pain control. Will this not lead to addiction? Will this not lead to overdose and so on? I think somebody talked about this earlier, that we fear. Remember, we are dealing with terminally sick people. People, you don't like the word, who may die, but you want a peaceful death. You want them not to suffer too much with their disease. So sometimes addiction is the least of your worry. But let me tell you, the VHTs can be trained. They can be trained to link the family with health facility, and also to give some simple medications that the health worker may not be able to do all the time and even monitor progress. So I think this is over-exaggerated by professionals to say, these VHTs will cause problem. I don't think so. If they're properly trained and supervised, there should be no problem. It's just helping us to be at the bedside where we are not present. And there was even an example given here. People fear to use morphine, even in a health setting, that it will be overused and so on. We just need to tune to what we are talking about here. We're talking about terminally sick people, people with very serious conditions, and you want to relieve them from suffering before the final day.
We have to be very careful that we are doing African palliative care. Africa is not the same as the West. And I'm afraid that was a big mistake we made with the COVID. We did exactly what was said for the whole world to do, send everybody into intensive care units. And people want to die at home in Africa. That's been proved with research done in 2003, published in the BMJ, here in 5 other countries. And they want to die at home as long as they can get services at home. And we talk about multidisciplinary teams. Where are you going to get them? Where are you going to get your OT, your physiotherapist? social workers, if you're very lucky, you will get a social worker who's good. But, you know, there's so many, who is the multidisciplinary team? It is the nurse. You, the nurse, are the multidisciplinary team. And about spiritual advisors, they're not trained here how to deal with people who are dying. They're terrified. They are scared. Somebody needs to go in and talk in the seminaries and talk to people who are going to be spiritual advisors. If you get them to go once, they'll disappear because they're scared. They don't know what to say. And you're bringing them very often very late towards the end of life, and they don't know that person. We have to be the spiritual person. We have to be able to talk to our patient about spiritual issues. And that means that we ourselves have to be very spiritual. To be in palliative care, you need to actually have a good relationship with your God, and to be able to talk to that patient at a level at which they are at. We don't talk to Muslims about Jesus Christ. We don't talk to the Christians about Muhammad. You work with them and be sensitive to their needs. But I'm very worried about spirituality because it's very difficult to get a priest or a clergyman to come out to them. And they are really frightened because they've never been trained. But it wouldn't take long to train them. Thank you very much.
Now, I just want to add to Dr. Okello. I think the experience here with the oral morphine that it doesn't cause addiction. The concentration is so small, and you need jerry cans to get addicted, to get high. Yeah. You need big volumes. It is very dilute. Number two, most of our patients come when they have a very short time. They will not have time to be addicted. They will be dead by then. So the issue of addiction is really in the clinical practice it is the doctors who are getting addicted. Now, lastly, I think we should know that most of our patients who are dying don't see health workers. The ones who see us are very few. Most of them die in the villages. And in the village, they do very good palliative care, except pain control. They don't have the ability. But the others, they do them better than us. I think we should learn on that. Yes, thank you.
You have the most questions. And you've got to really give us a promise that the time we've spent here talking about palliative care issues in the country, there is hope, right? That things will get better. That medical student said it was not like that before. That's quite a while ago. We need a new, it was not like that before. We need a new before.
Yeah, I think it's very exciting because just as Dr. Ann said, very many years ago, it was not like how it is. Even now where we are, because of the ministry talking about palliative care during Amandua's time was rare, but now we have a division. Yes. So I'm saying a comment about the policy. It's in advanced stages. We're almost there. The issue is the policy analysts are saying every department is coming up with a policy. How many policies are we going to have? We have already had a regulatory impact assessment. The issue of that assessment is to really find out, is the policy the best alternative or there's something else? But for the palliative care policy, I think after that assessment, it is that we need a policy for many other issues, including recognizing the staffs. And I'm happy to inform you that we are now going through structure formulation. I think at the national referral, we have already done that. Mulago structure is out, and I'm sure you know the cadres. Last time we visited your institution, and we need very many even consultants at that level with palliative care skills. I'm sure Dr. Namkwaya, you'll be one of the clients at that. But the issue is when we come to the regional referral hospitals, how many staffs are trained? They are not there, including Mulago. For those gaps you have, you don't have the cadres, including the nurses who have trained, who can fit in those cadres. So we're advocating that if people could go for the training, There are master courses, there are bachelor courses for palliative care, certificate courses for the nurses. Where we are going, the positions will be there for the people who are already prepared. I'm happy when Doctor brought out the engagement of the community. I think we need to benchmark on that model to see how we go. Because there's a lot we need to do if we are to offer palliative care. We are trying to pilot a district model because already almost all our regional referral hospitals have a department of palliative care. And Minister of Health, the Director General wrote to all hospitals that each and every hospital should have a palliative care department. But very few of them have. Already we have 13 regional referral hospitals which have palliative care, and now we are trying to see how we scale down to the general hospitals. But the issue is we still have a lot to do with engaging staffs. Many people are not interested in that. The worst are the doctors. So I think we need to convince the doctors and to show them that this is the way to go. There's no way you can become a specialist by not having palliative care on board. The other agenda which we need to promote is research. I think many areas we are just coughing without having evidence. I've seen there's a lot we need to have that, and we are working with the association to see how to go. I've taken note of many issues which I think there's a lot. The plate is getting flooded, but I think we need to work with everybody to ensure that we move as palliative care, and this is the way to go. Recently, we had a Zoom interaction with the Institute of, yes, the Institute. That's why she has now a lot of passion, and I think this is a better way to go. We are going to try to use technology to ensure that we reach many areas and we move. And I'm happy to see that all departments in Mulago are taking on palliative care. The Cancer, the Heart Institute, the Cancer Institute, and the Department of Internal Medicine, I'm sure even OBS and GYN. If at the national referral we are there, then I think we can be supported and we move as a team. Thank you so much. I know members are tired. The agenda is still big, and we continue engaging everybody into that. Thank you very much.
Wow, thank you so much, panel. Thank you so much, Assistant Commissioner. In the interest of time, and as you can see, the benches are beginning to empty, I would like to invite Mark, our Executive Director, to come and close the public lecture. Thank you, our panel. We can take our seats.
Thank you so much, everyone. I take the honor to close this very important public lecture. And if you didn't take notes, I took out 5 things that I'll read, and then you can have those notes. The majority of patients who come into hospitals, who come into Mulago, actually in one way or another require palliative care. Dr. Nakwagala mentioned that 14% of the patients who come into the wards here actually are at end of life. We are dealing with something that may not go away. We need to know how to address a problem that is not going to go away, how to live with it, how to adapt, how to work with it, how to make sure that we continue making life better. New technology and devices won't necessarily take away the fear of death, and therefore, even with technology, we need to make sure that we are human, we are addressing the human, not the disease. It is possible for a palliative care patient, or for any patient, to disclose to a medical doctor their social issue. And I think that was exemplified here. That I think Dr. Nakwagala even gave an example of the old man and his sons. And I also have my father who is unwell, and those things are real. Home-based care should not be only by the medical teams, but should be with the village health team and the district health team. We can learn a lot from the model by our chest. I think, Professor, you can give us those copies of the strategy. Is it possible? They're online. Thank you so much. Lastly, the last 2 points, African solutions for African problems. We need to make sure that culturally appropriate care is offered to families. Disability and inclusion of special groups is very important. Dr. Mwanga, I hope you took that. And the doctors here, it was requested that they should make sure that we don't leave anybody behind. At the Palliative Care Association of Uganda, we have put our goal for our strategic plan as universally and culturally acceptable palliative care for all in need in Uganda. Acts of Parliament, this was not mentioned very strongly, Dr. Mwanga. The Acts of Parliament that established the Uganda Cancer Institute, the Uganda Heart Institute, mention and emphasize palliative care as key. I would like to thank the following. All the speakers, kindly clap for them. Everybody who had effort in organizing this lecture, the Palliative Care Association of Uganda, Ministry of Health, the Makere team, please clap for them. We had a wonderful moderator for this afternoon. I think you agree. Clap for her. Let's clap for the senior citizens. We had Rose come, we had Dr. Mandra come, and we had Dr. Ann come here. And very lastly, as we clap for ourselves, we take these messages home. But we had a great team online. I was online even when I was here. We have in this room people who are called social media influencers. The doctors in Mulago, maybe you'll find that very interesting. There are teams of people who are social media influencers, and they have been doing a great job, so please clap for them as well. On behalf of the organizers of this public lecture, I want to appeal to all of you to continue with us. Tomorrow we'll have a series of TV programs on UBC, on NTV and NBS from morning to evening. And then on Saturday, no, before Saturday, on Friday, we have later on a Twitter space on access to medicines. Please join us at 7. On Saturday, we are going to be at Makerere Hospital Playground. I would like to request even the doctors, if you can spare some time to come and walk, we are going to be raising a voice about palliative care. You don't need anything. Just come at 7 in the morning with your walking shoes. We do the 4 kilometers around Mulago Hill. After that, we go home. Thank you so much. Oh, wow. I'm so sorry. There's going to be voices for hospice at Hospice Africa, Uganda, on Saturday at 2 p.m. And Rachel Magola, I think, has signed up. You know Rachel Magola of Obangaina. She has a swift voice, and she's going to be singing for patients as well. So please come and be in the audience. The Irish ambassador will be our chief guest. That will be at 2 p.m. Thank you so much.
Thank you, everybody. We can actually leave at will.